Hello and welcome to today's training, Exercise for Mood and Anxiety with Dr. Jesper Smits, PhD, and Miss Scarlett Baird, doctoral candidate in psychology. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. We will first kindly ask you to mute yourself so that we don't hear any background noise. To mute yourself, you will need to press the gray tab that is just below the red arrow in your control panel. Kindly also switch off your webcam. The webcam tab is just below the mute tab. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. You will also be able to access materials. If you registered and paid for continuing education credit, you will first need to provide the 4-letter C code on the webinar evaluation form. The link to the evaluation form will be sent to you 48 hours after the end of the professional webinar. You can either answer the post-test questions at the end of this webinar by staying online. These questions will appear at the very end. A screen will come up with questions. You will have 5 minutes to answer them. Simply click Submit once you've done so. And now I would like to introduce our experts. Jesper Smits is a licensed clinical psychologist and professor of psychology at the University of Texas in Austin. The main objective of his research program is to improve the treatment of anxiety disorders, social anxiety disorder, panic disorder, and post-traumatic stress disorder, and related problems such as smoking, overeating, and physical inactivity. Jesper has published over 150 articles, book chapters, and books. He's a member of the Scientific Council for the Anxiety and Depression Association of America and an associate editor for the Journal of Anxiety Disorders, Journal of Consulting and Clinical Psychology, and Cognitive Therapy and Research. A former Beck Institute scholar at the Beck Institute for Cognitive Behavior Therapy, Jesper's clinical practice focuses on behavioral and cognitive interventions for anxiety disorders, depression, and related problems. Jesper frequently gives workshops at national and international meetings and has authored a number of books aiming to assist therapists and individuals in achieving success in behavior change, including Exercise for Mood and Anxiety, Proven Strategies for Overcoming Depression and Enhancing Well-Being, Exercise for Mood and Anxiety Disorders, Therapist Guide, and finally, Exercise for Mood and Anxiety Disorders Workbook. And we have Scarlett Baird, who has received her MA in clinical psychology from the University of Texas at Austin, is currently a doctoral candidate in psychology. Her research and clinical work focuses on the implementation and dissemination of physical activity interventions for veterans transitioning out of the military. Ms. Baird is particularly interested in facilitating the acceptability of these interventions with the aim that treatment may be administered in diverse settings to reach a broader scope of the patient population. She's also interested in identifying determinants of exercise engagement so that clinicians are better able to gauge patient progress and anticipate and address potential barriers to progress. It is a true honor and pleasure to work with these two professionals. I will now pass the screen along to them.
I think we're on. Hi, my name is Jasper Smits.
And I'm Scarlett Baird.
We are your webinar leaders for this hour. And what I'd like to do is we'll go over the aims a little bit. An hour is kind of short. Usually when we do a workshop like this or a webinar, it tends to be longer. We try to get people maybe in for 2 hours or 3 hours. So I'm anticipating that people may have questions at the end, but if you have further questions, let's say you go home or tomorrow, feel free to follow up. This is on the first, both our email addresses. I'm happy to respond to other questions. I think we're both interested in helping people make exercise a prescription in their practice. As you start thinking about how to do that or how to fine tune it, and you listen to this webinar, and you have questions more about cases or how to best do it, feel free to follow up with us. Let's see, I'm trying to go to the new slide. There we go. All right, so the agenda. So think about this. We have about an hour, and what we'd like to achieve is that by the end of this, you feel maybe more comfortable prescribing the rationale, as in giving your patient an idea of why exercise might be useful in terms of helping them with their depressed mood and their anxiety. We want you to have a sense of how to go about this. So when you sit with your patients in practice, how do you go about actually discussing an exercise prescription? How do you go about actually putting it together so that people leave your office getting started with the physical activity program? Then obviously we want to leave enough time to talk about motivation. I think the one response that we typically get from people is like, exercise is great, but no one really does it. I'm going to say up front that that's not necessarily true. It's true that a lot of people don't like exercise, but actually it's something that we also see with other forms of intervention that we use in our practice, certainly with CBT. We obviously also see it with medication. So dropout or adherence is not new to us. When it comes to exercise, though, there are certain things that I think that we can do that help boost adopting a routine and making sure that people stick with it. So I'd like to highlight that much of this is covered in a book that I published with my colleague, Michael Otto, a few years ago. And so for further reference, you could take a look at that. I think it's also helpful for our patients. We usually prescribe it to them. But let us get started. The mistake that I always make when I do this is that I get sort of too stuck in discussing the evidence. And so I'm going to make sure that about 15 or 20 minutes in, we shift to more the practical aspect. But it is important, though, to discuss it. One of the ways that I look at this is when I go to get help and see a provider, and this provider prescribes a new intervention. For me, I always ask the question, well, why? You know, is this going to be helpful? How helpful is it going to be? And I'm also usually curious about why it might actually work. I mean, what are some of the mechanisms? And I think as providers, we need to have those answers, and we need to make sure that we're prepared to have that discussion with our patients. So as you think about the slides that I'm going to go through here, think about this as you building sort of the knowledge base of exercise for mental health. Some of the slides may actually slides that you want to use and hand out to your patients in terms of sort of bolstering their confidence in using this. So what I'm going to do is go through a series of studies that underscore both the effects of exercise and also a sense to how it works. Mechanism seems more researchy, I understand that, but as you'll see as I talk about the mechanisms, they actually have some implications for how we go about prescribing it. If we know how it really works, then we can also tell a little bit more about how to best time exercise. Should we maybe do it in the morning? Should we do it in the afternoon? Should we do it relative to certain activities? So more on that later. So I'll go through the slides relatively quickly. I understand there is an option to ask questions at the end, so write them down, and certainly I can clarify a little bit more at the end before we finish. Why exercise for mood and anxiety? I think you'll ask anyone, is exercise good for you? Most people will say, sure. So it's sort of a no-brainer, but this study here was conducted, about 30 years ago in Canada. And what they basically asked or compared is people who exercise versus people who don't. And what you see here are the characteristics of people who exercise. And as you can see, people exercise have fewer symptoms of depression, anxiety, less anger, less cynical distrust, and then stronger feels of social integration. I think the first four, or maybe the first three, are not surprising to most of us. I like the last one, stronger feelings of social integration, because I don't know if this is true for you in your practice, but one of the things we find is that people often feel isolated. And if you ask the question, what are the terms or keywords associated with happiness, it tends to be connectedness. And so physical activity seems to be a way for people to feel more connected and more integrated with others. This has also been studied in large samples. What you see here on this slide is a prevalence study, or I should say an epidemiological study, the National Comorbidity Survey. And they basically asked the question whether the prevalence of anxiety and mood disorders varies depending on physical activity. And they just did it sort of a rough split here between people who are active, regularly active, and then people who are inactive. And the results are noted on this slide. So what you see here on the x-axis are the different disorders. So you have major depression, social phobia, all the way to GAD. And this is the prevalence rate, again, split up between those who are active and those who are inactive. And as you can see, across these disorders, those who are active are less likely to have a disorder. And the effect is almost sort of like double. You can see that the prevalence rates among those who are inactive tend to be about double of those who are active. This is obviously a correlational study. We all know that this doesn't imply any causation. I mean, it's certainly true that if you feel better, you're more likely to work out. But at least some evidence to suggest that exercise is associated with less likelihood of these problems, lower likelihood of these problems. The next study was done in Germany, and they sort of followed up and asked the question more of causality, not in a perfect way, but they basically asked the question, is it a predictor? So if we follow people over the course of a few years, in this case 4 years, are people who are active less likely to develop problems during those 4 years relative to people who are not? And here they split it up in 3 groups: regular, non-regular, and not active. And so this gets a little bit more at a potential protective effect. So does exercise protect people from developing problems? And as you might expect, that is the case. So the incidence rate, so new problems with anxiety disorders, were most elevated in those who had no activity, less elevated in those who had non-regular activity, somewhat active, but not fully active at all. But those who are really active showed the least, the lowest likelihood of developing a new problem. And again, these effects are pretty big. It's about half the risk that you see in regular activity relative to those that have no activity. All of these are correlational. We like correlational studies, mostly for getting a sense whether our hypothesis has any sort of validity. But as we know, when it comes to an intervention, and that's true for our medications, it's also true for our psychotherapies, we only get confident in efficacy and the effects of intervention if they're subjected to randomized controlled trials. That's FDA gold standard way of testing the efficacy of interventions. And that's been done, I would say, and I'll start with this, mostly for the treatment of depression. So among people who are depressed, they've tested whether exercise does better than a placebo and how it compares to, let's say, an established medication, in this case Zoloft. So this is one of the larger studies done by Jim Blumenthal and colleagues at Duke. And as you can see, 202 people were randomized. They either did supervised exercise, home-based exercise, Zoloft, or pill placebo. Tell you a little bit more about exercise. You have a sense, and we'll get into that later. Scarlett's going to talk about this. In this case, they use vigorous intensity exercise. And so don't worry too much about the definitions here. We'll talk about this later. But essentially, people were asked to be on a treadmill and walk or run at a speed to where they can no longer really hold a conversation. So their heart rate's up, they're breathing faster, and they're really putting in quite a bit of exertion. And again, they had people either do that in the lab, or that people do this at home. They were trained to do it in the lab, and then they did most of the exercise sessions at home. This was compared against sertraline or Zoloft, prescribed per guidelines, or pill placebo. And then these are the results. First, about attrition. As you can see, supervised was more challenging than home-based, but certainly all were comparable in terms of the active interventions. So no differential dropout between Zoloft and exercise. Those in placebo were most likely to drop out. More about dropout later. And these are the findings. These are remission rates. So these are people who walked away after 16 weeks saying, it's out of my system, I no longer have a major depressive disorder. And as you can see, all treatments outperform placebo, and all the treatments, active treatments, actually perform similarly. So supervised and home-based were about the same, and they were comparable to Zoloft. So I think this is solid evidence, at least from this particular study, that exercise can do something similar to medication, and people show up with mild to moderate forms of major depressive disorder, and it outperforms the placebo condition. This is a little bit of a tricky slide, so I'll go through this quickly, but this is just to show that as people continue to exercise in the follow-up period, and this was during 12 months following the intervention, they were less likely to see lapse or relapses during that period. And this shows a little bit of a dose-response relationship. Let's just take a look at the right graph, which shows that the probability of staying in remission increases as people exercise more. And the point at which there was no additional effect seemed to be at about 150 minutes. So at that point, the protective effects of exercise, continued exercise, were achieved. Beyond that, it didn't seem to yield additional effects. But it does show that this is not something that we just want to teach people to do for 15 weeks. But if we want to make sure that people maintain their effects, we want to make sure that they continue to exercise following the intervention. This next slide, I'm noticing the time, and I want to make sure we have enough time for the practical issues. So I'm going to go through this more quickly. It's just in your slide set for review later. This study shows that you can actually also add exercise to existing forms of treatment, in this case pharmacotherapy. What this study showed is that people who are already receiving medication, yet not responding to it, would do well with high-dose exercise if that was added to it, and better than low-dose exercise. Note that in this case, low-dose was really more based on how many calories they burned. Everyone sort of walked or ran at a level that's considered moderate intensity exercise. So take home from this is, we are not suggesting exercise should be done just as a single modality treatment, but evidence suggests that you can add it to other interventions. And in some cases, like here, boost the efficacy of those interventions if it's coupled with exercise. This is a meta-analysis, real quick. So pooled all the studies. For those of you who are not familiar with effect sizes, once it goes over 0.5, we consider this a clinically meaningful effect. As you can see, 35 studies combined show that exercise is better than doing nothing, and at an effect size of 0.62. And these studies also show, although they're small in number, that exercise doesn't seem to be different from psychotherapy, it's a very small effect size, or from an antidepressant medication. So a little take home, I think at this point it's fair to tell our patients the evidence base for exercise for mood and anxiety disorders is strong. It's certainly not as large in terms of the number of studies as it is for antidepressant medications, or let's say something like CBT. But the effects that are there suggest that it's an effective treatment for mild to moderate forms of depression, and it's comparable for those cases relative to psychotherapy or antidepressant medication. As I mentioned earlier, people are worried about attrition. This study shows that attrition is somewhat comparable to what we see in psychotherapy and CBT. So people, once they are in your practice and starting to exercise, seem to do about the same in terms of adherence relative to other forms or modalities of treatment. Exercise for anxiety is less well studied. I will say that there are a lot of studies, but they look mostly at people who have anxiety problems, let's say, when they also have a medical problem. The large RCTs for anxiety disorders are lacking. So when we look in terms of, when we look to the effect for exercise for anxiety disorders, we base it on those smaller case studies. But what we see when we combine those is that exercise, again, is more effective than control. It's about the same as CBT. And as you can see, it compares relatively well to other forms of intervention for anxiety disorders. Small-scale trials are available for panic disorder, for GAD, mixed anxiety disorder samples. So I'm going to go through this relatively quickly, mostly just sort of show that I think we can be confident prescribing this for our patients. The evidence base is there. So let's talk about the next piece, which I do think is important, and that is it maybe the case that exercise is more effective for some people than for others? And we now have some evidence to suggest that is the case. And the only reason I'm saying this is that once you start working with your patients, you'll find that, hey, for some people, exercise is going to really do wonders, whereas for others, the effects may not be as strong. And that simply has to do with what exercise can do in terms of targeting certain problems that are implicated in anxiety and depression. So more on that. Here, I'm rushing through this a little bit. I want to talk about two things because I think they're mostly relevant for people in practice. One is reduce stress reactivity and reduce anxiety sensitivity. We and others have now shown that if you prescribe exercise, you can actually buffer the effects of stress, and you can also help reduce anxiety sensitivity. So think about this for a minute. When you have people in your practice with anxiety sensitivity, that is, they have fewer bodily sensations, we do all kinds of things in the session with them, such as interoceptive exposure, cognitive restructuring, and so forth. Exercise seems to do something that's very similar, and that is to help people feel more safe around the bodily sensations that they fear, as in racing heart, maybe uncomfortable, but not something that I'm really scared of. Sweating may be uncomfortable, but it's not going to lead to anything else. So exercise can be used to reduce anxiety sensitivity, and it can also reduce stress reactivity. And what I mean by that is that when we are exposed to a stressor, we have all kinds of reactions, both physiological reactions such as increased heart rate, increased blood pressure, all the kind of things that many of us find very uncomfortable. When people exercise before a stressor, their reaction to the stressor is much less intense. So they have less physiological reactivity. They also have less psychological reactivity. So it almost sort of acts as a buffer in that when you prescribe exercise beforehand, you subject people to a stressor. It's as if they can brush it off a little bit more easily, and it doesn't hit them as hard. So I'm going to skip these studies mostly in the interest of time. But they're there for your reference. I just don't think we have time because it's 11:24. I just wanted to show this graph here, which I do think is a nice one to show to some of your patients. And this has to do with stress reactivity. So what they did here, and this has also been replicated in experimental studies, they took men either that were trained or untrained, so people who exercise a lot of people who don't, and they subjected them to a stressor. And as you can see, those who were trained reported less heart rate reactivity, and they also reported less cortisol reactivity. So this is a nice piece of evidence supporting that when subjected to a stressor, exercise can really buffer the effects. We'll talk about this a little bit later, but one of the clinical implications here is, and this is what we do in our practice, is obviously most of our people report stressors that we see in our practice. But those stresses come on at different parts of the day. Let's say someone has a stressful meeting, someone has a stressful living environment at home. What we do relative to the prescription is we ask people to exercise before they enter those environments. And so if someone has a meeting, let's say at noon, we recommend like morning exercise because we know that when they enter that meeting, they're more likely to actually perform well in that meeting and feel much better because they're less likely to experience stress or the effects of stress. Yes. Let's move to this area, and Scarlett will take over here. I'm sorry I had to rush through it. It's mostly in the interest of time, making sure that we have enough time for more of the applied piece. When you review this at home, you have more questions, I'm obviously happy to further clarify. The take home with this, again, for your sessions is that you should feel comfortable talking to your people about using exercise in their practice or for their mental health, as in when people engage in exercise, they sustain the activity for several weeks. The large trials last for about 16 weeks, so that's sort of the common prescription, that they can start seeing the kind of effects that we also see with, let's say, CBT or a medication. We also noticed that for certain people, those who are particularly stress reactive, or those who are particularly afraid of their bodily sensations, exercise may be particularly helpful. And so when you identify those people in your practice, exercise is even more meaningful as a way to get them to overcome their problems with anxiety and mood. So let's move to the more practical aspects. Scarlett's going to talk about the prescriptions or more of the logistics. How do you get started with this? And then we'll finish talking a little bit more about motivation.
Great. So in terms of talking about the prescription, there isn't a lot of clear guidance as to how to best go about this. So a lot of times people will ask, how do we initiate an exercise program in terms of what type of modality do we do? Should we do aerobic exercise, so more running, biking, jogging, those sorts of things, or anaerobic exercise? So that's more your strength training, weight training. And the research is really mixed on this. There are some studies to suggest that there's not really a difference between the two. However, there is a lot of literature supporting or studying the effects of aerobic exercise. And so for the purpose of these next slides in today's webinar, we're really going to focus on the evidence base, which is on aerobic exercise. So you can see the prescription here, and these are the public health guidelines. So you have moderate intensity aerobic exercise for at least 150 minutes per week, or vigorous intensity aerobic exercise for at least 75 minutes per week. This is nice because these are geared more towards overall like medical problems, and usually are prescribed kind of by the primary care physician. But it's nice because while the primary care physician may say, hey, try and meet this, it'll improve your overall health, you as a psychologist, social worker, mental health provider can also be in line with that same prescription. In terms of exercise, it's always important to talk about risk and to keep that in mind. So you really have to think about your practice, who you're working with. Here we see, I would say, a lot more low to moderate risk. In terms of the prescriptions that we're suggesting today, I would say that most people are able to engage in the exercise, but it is definitely something you want to keep in mind depending on the setting that you're at. So if you're in a hospital setting, let's say, and you have people more at risk for cardiovascular disease, pulmonary disease, that's something where you would definitely want additional testing. So staying on that slide, you can take a look and you can kind of see where people fall. So obviously low risk is no more than one risk factor, moderate 2 or more, and high risk is again, indicative of maybe more like a hospital setting. So some of these risk factors, these are outlined in the ACSM guidelines, the American College of Sports Medicine. You can take a look further. I think much of these we're all pretty familiar with. So family history of cardiovascular disease, cigarette smoking, obesity, sedentary lifestyle, all things that you want to keep in mind. And you know your patients, you may have a sense of some of these, but it's also definitely worthwhile to ask about prior to getting started. So depending on where they fall in terms of low risk, moderate risk, high risk, I think it's important to determine whether or not they need a medical exam and whether or not we need to involve the primary care physician. So if an individual falls in a low risk category, that's not really necessary. And again, that's much of what we see here. Sometimes we do see some individuals with moderate risk. And so what we would say is that they are typically safe to engage in moderate intensity exercise. And I'll define in a little bit kind of what activities fall in line with those. But once it gets to more vigorous intensity, that's definitely when you would want to seek consultation with a physician. And by all means, definitely with high risk individuals, regardless of the type of exercise, you definitely want to consult with the physician. I typically approach this in a very collaborative manner. So, you're just letting the patient know, hey, this is what we're going to be doing. And we just want to basically make sure we have all our boxes checked. I'm happy to talk with the physician as well. But you just really want to err on the conservative side and make sure that there's no risk of injury there. So in terms of intensity and deciding whether or not to do light, moderate, vigorous intensity, just to give a brief overview, light intensity is really no more than walking around. It's just very, very light activity. Moderate is definitely where you start to see more of an increase in heart rate, and vigorous is definitely where patients, they can tell you that they're pushing it. They feel it, it's pretty obvious. I'm running a trial right now, which I'll reference throughout the future slides, where we are prescribing 3 sessions, 25 minutes of vigorous intensity exercise. And often I run into the issue of figuring out, are these individuals working out at a moderate or vigorous intensity level? And I think the best question you can really ask there is, are you able to hold a conversation during your run? And people can usually conceptualize and think back to that and say yes or no. And so if they can't hold a conversation, you know that it's really more into that vigorous intensity range. In terms of calculating this, we stick with a pretty simple formula, which is looking at your heart rate max. So this is where you can really kind of tell the patient where they need to be working out at. So that's just 220 minus their age, and then you're able to compute the percentage accordingly. So let's say you're working with, for the sake of simplicity, a 20-year-old, 220 minus 20, 200, and you want to prescribe them at moderate intensity exercise. You would tell them, we'll go over monitoring in a minute, but you would tell them, we don't want you over this 76%, which for you would be 152 beats per minute. And so that way they can actively monitor kind of where they're at within this range. Finding the right activities. So this is definitely getting to kind of more of that first section of exercise counseling. And it's really important. I mean, it sounds kind of simple, but we definitely don't want to brush over it, because I think this is where we can really differ from the primary care physician, in that the primary care physician is going to say, exercise for the 150 minutes, it's good for your health, get to it. And that's great. And this is not to point fingers at the primary care physician, but it's really, oftentimes patients leave understanding that, but not really knowing how to implement that. And so I think as we move through these next few slides, it's really helpful to conceptualize it as like behavioral activation for a depressed client. So here we really want to select the best activity. We know that they're more likely to engage in it that way. So here we have some different types, listed out of moderate intensity versus vigorous intensity. And again, this is up to you. I would say we typically start with kind of walking or running as the default, and then deciding the intensity accordingly. But, oftentimes that's just really for feasibility purposes, because many people can manage, opening their front door, going outside, walking around the block, taking a quick jog. But some people will tell you there's no way I'm running. And that's really where you have to get a bit more creative and figure out what other activities can we do? Can we do a class? Can we do swimming? Is there a sport that they really love? Just because not only are they going to be more likely to engage and is it going to be more feasible for them, but hopefully it's also more appealing. So you definitely want to leave on the same page, kind of excited about the selected activity. Developing an initial training schedule. So here I want to talk a little bit about the use of the heart rate monitor. This is particularly useful at the beginning. So some patients already have access to this in terms of like a Fitbit or an Apple Watch. it's helpful because it provides initial feedback in the session and it lets them know the pace at which they need to be exercising, really. So we can answer more questions about that afterwards. I know we're kind of running short on time, but you know, it's very appealing for a patient, for instance, if they have the Apple Watch to close the activity rings a lot of times, or if they have a Fitbit to meet a certain number of steps. So I would definitely recommend including something like this, and that just also helps guarantee that your prescription will be met in terms of intensity. So be specific, we talked about that in terms of which activity you choose, but I would also go so far, I mean, in the trial that I'm running, we will give them a calendar and we're scheduling these activities. We're scheduling, is it gonna be 25 minutes? So I'm prescribing, like I said, the 75 minutes per week. And so we'll actually get the phone out, put it into the calendar, set reminders on the phone. I worked with someone yesterday. We had him text his 2 buddies to say like, hey, you guys are going to keep me accountable on, you know, this day and this day to make sure that I'm out of bed and going. Particularly at the beginning of behavioral change, we really want to focus on that accountability. So whether that's you as the therapist kind of texting, hey, you know, 10 a.m., it's time for that run, whether it's a buddy, spouse, it's really important, particularly at the beginning, just to get the patient engaged in the activity. So I would recommend definitely picking the right activity, picking a time, picking a place. Is there a trail that they like? Is there a gym that they're going to go to? And just making sure that it's really feasible for them. You may also run into the issue where someone, you know, used to be an athlete or ran in high school and they say, well, I ran track in high school, so I'm going to do the 75 minutes and I'm going to run, you know, 3 times, 4 or 5 miles each time. And while ambition is great and that's awesome and it shows that they're on board for the intervention, you also want to set them up for success. So what I would do in that situation is maybe say like, all right, let's do maybe 2 times at this intensity. So you don't have to jump into the full prescription right away. Like a success to me after that first session of counseling would be, by the time I see you next week, you, depending on the patient, you'll have run 1 time, 1 mile. Let me know how it goes. So that they get the sense of, oh, I can put this into my schedule. And then you can start to build up more and more into the prescriptions that we kind of indicated at the beginning. But that's a success that is measurable, that we can look at like, hey, did you do your run? And that's definitely will make them more confident that this is something that they can implement into their schedule.
All right, so I'll move on to the next set, which talks about motivation, which very much follows what Scarlett's already talked about. And basically what I'm going to do is sort of think about ways, like some tricks, so to speak, to help people adopt a routine. We obviously as providers always work with behavioral change, and as Scarlett already said, I do think behavioral activation is like a really good model for this. And so most of you who are not at least familiar with exercise, but are familiar with behavioral activation know that this is really challenging. We're asking people to do something that they're not doing yet. So how can we come up with some tricks so they're more likely to do it? So let's talk a little bit about motivation. I think one of the things that's beautiful about exercise for depression and anxiety relative to exercise for physical health is for the latter, for physical health, we know we have to do it for a long time. If we want to lose weight, you got to exercise for a long time and also eat very well to achieve that. When we tell people exercise like our primary care physician does is good for your overall health and longevity, few of us wake up in the morning and say, well, maybe today I should exercise so that in 20 years, you know, I feel like I can benefit from it. Most of us are more interested in doing something that we can get something out of today. And that's where exercise for mood and anxiety comes in. Because one thing that we know is that even though many people don't always enjoy exercising while they're doing it, we can say that 95 to 100% of people, when they finish exercise, will say like, you know what, I feel much better than I did before. And that's reflected in this particular slide, which just shows you the decreases in depression, tension, and anger and distress following a 30-minute bout of exercise at times. So 5 minutes after, 30 minutes after, and 60 minutes after. So you can see that we all feel much better right after an exercise bout. And I think we can leverage that with our patients. So one of the things that we do, coupling with what Scarlett has already said, like aiming for success, is we use tracking with people particularly early on. As we want them to get motivated to exercise, we want them to see the evidence of exercise in terms of how it helps them on any given day. So when we do the initial prescription, as Scarlett just said, let's say we just have them go twice a week, run for a mile, we ask them, hey, can you just before you go rate your mood beforehand, what your thoughts were, what your energy level was, and then also do it again afterwards. And then we ask people to bring in these sheets, or we do it online, into the clinic, and we review it with them. And this is kind of the first piece where they can say, like, you know what, based on my experience over the last week, maybe this is a good thing for me, because I can see that on the days that I exercise, I actually feel much better than on the days that I don't. Now, this is just kind of a general tracking form, but you want to specify or modify those for each of your patients. So when we have people who say, like, let's say I have really trouble sleeping, one of the things we know is exercise is really effective for sleep. So we'll add sleep. On the days that you exercise, you should sleep any different. Or any kind of outcome that we know we can improve with exercise, we add to this tracking form. And then we can start building the evidence that exercise is actually a good thing for them. Little thing about motivation, a lot of people come to us for anything, right? But especially for exercise, like, you know what, I will start exercising when I'm motivated to do it. And so a lot of people think sort of as motivation as this thing that will happen. You wake up one morning and you'll feel motivated to do something. And we know that's not the case. In fact, we know that we're motivated for lots of different things. Yet it just tends to be that these motivations are in a particular hierarchy. So let me give you sort of an example of this. So consider this guy laying down on the sofa after a hard day of work. What is he motivated to do? Well, he's motivated to do a lot of different things. He's motivated to do a workout. He's motivated to play a game or chat with a friend or watch TV. But when you lay down on the sofa, you're more likely to be motivated to watch TV. So that's sort of the motivation that's at the top of the hierarchy. That's the thing you're going to do most quickly. You turn on the TV, you see a commercial for, let's say, fast food. All of a sudden, eating, let's say, a hamburger climbs up to the top of the hierarchy of motivations. So we know that we're really sensitive to environmental cues. When we surround ourselves with particular cues, we're more likely to actually be motivated to do something that reminds us of that particular cue. So this is where we can come in as providers, is to figure out ways with our patients to manipulate their environment so they're more likely to have a motivation to work out at the top of their hierarchy. So let's go over a few of these things that you can do, context. So time cues for exercise, people cues for exercise, location cues for exercise in the gym bag. So these are all little things that you can do that make engaging in exercise more likely. So as Scarlett said earlier, if people use their phone for their calendar and they use it for reminders, any other types of appointments, we make sure that we put exercise on the calendar. We make sure that if people engage in morning exercise, that we have the gym bag already ready and that we have it right next to their bed. In fact, some of our patients will actually sleep in their workout clothes if they choose to exercise at 6 in the morning. Because it's just one less step. The alarm goes off, you look down, you're like, wait, I'm already dressed. Hey, here's a reminder for exercise, therefore I'm more likely to do it. So these are just some examples of little tricks, but little things that you can do. And that obviously requires a conversation with your patient. What you want to do is, it's like, for you, what's going to trick you? What's going to get you to be reminded of exercise so that you're more likely to do it? Let's see, whenever possible, combine motivations. I'm going to skip through this, mostly because we're all motivated to do other things and we never give up on these. This is like a good example that my co-author Michael Otto described in our book. He says he has very little time for reading because he's busy with so many other different things. So he's turned to actually listening mostly to audiobooks, and he's decided that he's going to tie listening to audiobooks to running. So he's always motivated to listen to audiobooks, but he's now said, like, I'm only going to listen when I run. So I happen to find myself running and when I'm actually listening. So these are just, again, other little tricks that you can think of. One thing that we obviously notice is that, and this is true for all kinds of new behaviors, that it's hard and really difficult to do something that requires an effort like exercise if we are already pushed in many other ways. So this slide tells you how we push ourselves and how we engage sort of our self-control muscle throughout the day. Like when we go to work, we have difficulty with our boss, we have to refrain ourselves from engaging in an argument. We go to lunch, we saw all kinds of things that we want to eat, but we say like, we're not going to do that. So that's engaging the self-control muscle. You have other stressors that you are working through as you come home again. And then you have exercise. And so you have to ask yourself the question, well, can I even do this when that muscle is so strained or used throughout the day? And there are tricks for that as well. And what we do, or what we suggest as it relates to exercise or any of these kind of difficult behaviors to engage in, is to conserve the muscle by using chaining. So what does that look like for this guy who is thinking about exercise? Is rather than telling him, hey, next time you're lying down on the sofa, why don't you just go out for a 5-mile run, is we break it up in different steps. So we say like, you know, the first step might be that you put on your running clothes. The next step might be that you go outside. The following step might be that you run, and then the last step might be, that you walk, and then the last step might be that you run. And so when you break it up like this, an interesting thing happens, and I'm sure many of you are familiar with this, is the moment you put on your running clothes, it really feels like it's more likely that you're actually going to go outside. Because, hey, I have my running clothes on, so why not go outside? The moment you go outside, you're just committing just being outside, it is easy to start walking. And the step from walking to running is so much smaller than it is from being on the couch to running. So you think about chaining like this, and these are little tricks that people can engage in to help achieve that outcome of actually meeting the exercise prescription. Skipping through, kind of keeping track of time, many of us use cognitive restructuring throughout our work with patients with anxiety disorders. This obviously also comes in as it relates to exercise. We think of this as a behavior that we need to prepare people for before. We also think of ways in which we can make exercise more tolerable during. And then we want to make sure that the effects really last, and that is that people really, after exercise, give themselves the credit for doing it, attend to the mood benefits of exercise, making sure that that sort of sticks in the memory of like, hey, this was a good thing for me. Again, helping them to feel more motivated to stick with it. So what do we do in terms of coaching? We have obviously people who have all kinds of negative thoughts. One potential thought is when people see exercising others, whether it's outside or in the gym, it's like, that's never going to be me, and therefore, why would I do it? That's a target for intervention, as in getting people to at least consider that that is a negative statement, that is something that people can become more flexible around, and motivating people to actually give that a try. We sort of break this up in our book in terms of the times for exercise when particular negative thoughts come up, whether that's in the morning, the afternoon, or the evening. So let's take a look at morning, for example. Many of us who've tried exercising in the morning, including myself, recognize many of these depending on the time of the year. But hey, it's too cold to get out of bed. It will be more valuable for my mood to sleep in because I'm sleepy. Missing my workout is not going to be a big deal. I'm too tired to exercise well. So these are sort of normal, so to speak, thoughts that people face when the alarm goes off in the morning. So how do we prepare people for that? Is rather than trusting that they are very effective with a sleepy mind to address these when they wake up in the morning, we make sure we address those in the session. We come up with little notes that people write themselves, little counter arguments that they have that they even put on sticky notes right next to their bed. Things that they can do almost as in like, hey, there it is, the alarm goes off. I know that I'm going to be hit with these particular thoughts. Happens all the time. But these are some more adaptive thoughts that might help me get out and go for my walk or run. Manage the aversive aspects of exercise. We find that, and Scarlett mentioned this earlier, particularly early on when people are just new to exercise, that they find it immediately sort of aversive. This is not what I want to do. And that's often because they overdo it. And also gets them maybe into injury. So this is another reason for people to really start more slowly and to get people more comfortable with the act of exercising, making sure that their bodies get used to the activity so that we really use some good training progression. Then there are also people who are just afraid of their bodily sensations. While we can address that with exercise, there are also other actions that we can take, is getting people to relate to their bodily sensations differently by giving them some information about the negative effects of exercise and counteracting some of their negative thoughts. Some people are concerned about exercising in front of others because of how they appear. We slowly introduce that. We make that part of the process, much like we do in, let's say, social phobia, or the treatment of social phobia. So these are all things that you want to anticipate. As you can see, one of the things that we do is the exercise prescription is relatively straightforward, but we sort of think about this mostly in terms of what are the barriers that we're going to hit? What are the reasons why people might talk themselves out of doing this? Can we anticipate those up front? And then can we fold into the session strategies that can help change some of these barriers or overcome some of these barriers?
And I would add one thing to that actually, which is I think what's helpful is a lot of people conceptualize themselves as either exercisers or not. And so in the beginning, as you're coaching them through this, they may report that it was horrible during, and yeah, they felt a little bit better after, but I don't know if I can do that again. And so it's particularly helpful if you've had clients who have gone through exposure therapy or who've had other experiences. Maybe you can ask them about this, where it's been really uncomfortable and difficult at first and it gets easier with time. Because I think it is very similar to exposure. It feels really uncomfortable, and then as it starts to become more of a habit and as you start responding to these sensations differently, it does change the way you think about it. And the more that obviously it happens with time, they will feel that mood boost lasting a bit longer. So it's really kind of normalizing. I get it, I'm with you, it's not fun, but just hang with me for a couple weeks. And let's figure out a way we can put this in.
Yeah. I like that point, and it reminds me again that it's helpful to use some sort of tracking, making sure that people are aware of these, aware of the changes. Hey, remember how you felt last week relative to how you feel this week about it. And so when people start seeing progress and their own evidence that they're getting more comfortable with this, that again builds the motivation to stick with it. I'm looking at the time, it's 11:53, so we have about 7 minutes left. So I'm going to stop here. As I said earlier, plenty of time to engage with us after this over email. But I think Helen's going to take over and then maybe feed us some questions here.
Thank you so much, Jesper and Scarlett, for your excellent presentation. We're now going to start answering some of the questions that were submitted during today's presentation. And as a reminder to everybody, you can still submit questions to the chat panel in your attendee control panel. Now, here's the first question. I'm from a clinician. I mainly treat OCD using exposure response prevention. Is there any data regarding whether adding exercise to ERP improves treatment response in patients with OCD? Most of my patients are children, teens, and young adults.
So I'm going to say that that study has not been done, but indirectly there's evidence to support this. One, there have been some trials, although they've been done with adults for OCD, showing that exercise shows some really nice effects for OCD. What I'm going to say is that where the effects of exercise can really come in terms of combining with ERP are two things. One is exercise obviously improves mood, because we know that mood can really get in the way sometimes of doing exposure therapy effectively. So think of exposure as like a stressor, like I just said. So if you ask a person to exercise before, let's say, a session, they're much more likely to be willing to engage in the exposure exercise and to also get more out of it. Another piece of evidence, and that's maybe less strong, but it's at least sort of indicative of that, is that exercise seems to engage some of the circuits that are really involved in learning and memory that ERP also relies on. So you can sort of think of exercise as a way to optimize our system for learning. And in that way, it's also a perfect method for combining exercise with a learning-based intervention.
Thank you so much, Jesper. Here's a research question. Are there any studies on high-intensity training alternating moderate with brief periods of more intense exercise?
I haven't seen that many studies. I did see a study, I believe it's actually under review at this point, from a group in Germany that has taken a look at this. And they actually looked at it mostly from a feasibility perspective in people with panic disorder. So the answer is it's not there. Conceptually, you would argue that it might be particularly useful, again, for people with high anxiety sensitivity, mostly because it really gets the somatic symptoms up and allows people to learn to feel more comfortable with it. So at this point, no reason not to do it, but there's also no strong evidence yet that it's really effective.
Thank you very much. Here's another question on exercise as prescription. How quickly can one see improvements in mood with a weekly moderate exercise routine? Are there any studies on this? What is your experience?
Yeah, so the studies, as I mentioned, or at least alluded to, I know I went through that relatively quickly. Most of these studies are similar to our psychotherapy or medication studies in that they're usually 4 months in length. And so you do see a sort of a gradual improvement in symptoms. And they happen much like with psychotherapy relatively soon. I think the evidence just says like the stronger effects when we talk about like remission and really overcoming like a problem like major depressive disorder, those seem to take longer. I would also say that one of the things that we see in our practice is that we see the immediate effects mostly on the day-to-day basis. So again, the days that people exercise, through the tracking, we see this, are the days that people really feel better. And so from that perspective, I would say like, yeah, you see them immediately, but more sustained in terms of actually having it out of your system, that'll take a little longer.
Thank you very much. Here's a question on research studies. Are there any studies on resistance training and mood that you're familiar with?
I think there's a set of studies that's done well as it relates to generalized anxiety disorder, which is sort of related to mood. One early study in the late 80s actually compared resistance training to aerobic exercise, and it didn't see a difference. And the meta-analysis also shows that there's really no differences there. I will say, though, that the longer and sort of the better studies on this haven't really been done. For GAD, it's been studied. There is a group at the University of Georgia that's done this and found that resistance training might actually be really effective for GAD, but these are also small-scale studies. So at this point, and I think Scarlett mentioned this, we recommend aerobic exercise, mostly because the evidence base is strong for that. We don't recommend against using anaerobic or resistance training. We just don't feel as confident about it because the studies are just so small, and there are just not a lot of studies having taken a look at that.
I've also noticed in preparation for my dissertation that there is a lot of emergent literature coming out about that for the military population. So I would definitely recommend looking in that area as well. It seems to be highly popular in this group. So you'll see evaluations of, high intensity interval training or something, more like CrossFit or weight training. And so there are studies definitely coming out. It's an up and coming area for sure, but still pretty new.
Thank you so much, Jesper and Scarlett. Here we have 2 more questions. We were looking at different types of exercise. Does yoga count as moderate exercise?
It depends on the type of yoga. In our lab, we've used Bikram yoga, which is really more of an intense exercise, not so much the poses, but mostly the fact that it's in the heat. So there's obviously power yoga, which tends to be more cardio. I would say that the traditional yoga that we think of would be considered moderate intensity, certainly not vigorous intensity.
Thank you. And our last question, you were talking about ways to manipulate the environment for motivation. Now, based on your experience with the clinical trials, which factor do you think would be the most determining for patients to increase their motivation?
I would say the first piece that we highlighted, which is attending to the immediate effects. I find that to be very powerful. That obviously doesn't have anything to do with the environment, but I'll get to that quickly. But once we can get people to see in a brief amount of time, like every day you do this, you actually feel better, much more likely to actually get to it. The other piece in terms of environment, and Scarlett mentioned this, is accountability. So when we involve other people, it doesn't have to be group-based exercise, but when we either as a clinician are there to check in with people, or they have a buddy that can check in with them. Those are things that are really helpful in terms of getting the person going in the beginning.
Well, thank you so much, Jesper and Scarlett, and thank you to all the participants for attending today's webinar. You'll receive a follow-up email within an hour that includes a link to the evaluation and a link to the recording of the webinar. Please do share your thoughts, even if you're not requesting CE. I would also like to share that the CE code is LWID. LWID. If you're not yet an ADAA member, please consider becoming one. ADAA offers an excellent member benefits package such as year-long access to continuing education, free access to special interest groups, including peer online consultation groups, significant discount to ADAA's annual 4-day conference, promotion of your practice in ADAA's online Find a Therapist database, and much more. We hope you will join us at the Anxiety and Depression Conference early April in Washington, D.C. On behalf of ADAA and our presenters, thank you very much for joining us today and have a great rest of your day.